We shall go on to our next speaker, Dr. Naresh Babu from Arvind Eye Care Systems, Madurai, who's going to be talking on approach to cataract patient with diabetic macular edema. Thank you, Dr. Rajnarayan. That was a wonderful talk. Stay with us.
Thank you, madam. Hope the slides are visible. I am audible also.
Yes, sir. Yes, sir.
Yeah. Thank you, Dr. Srinivas. Actually, long time back, I have read the advertisement for this Amachitra Katha. 5 brothers fought against 100 cousins. So it is an ad for Mahabharata. So the bottom line says, if Mahabharata is so simple, it wouldn't have been an epic like that. It's a bit difficult for me to cover everything in 6 minutes. And of course, the title is Approach to Cataract Surgery in Eyes with Diabetic Macular Edema. There are 2 ways of approaching it. One is from the anti-segment surgeon's point of view. The other one is from the post-segment surgeon's point of view, which I'll be talking actually. So how the anti-segment surgeons approach, I really don't know, because many times we get the cataracts done and then come to us. So the problem with the cataracts in diabetics is the prevalence of cataract in diabetics is quite high. It is almost 5 times or 5-fold more than that of the non-diabetics. And if you come across a cataract in patients less than 40 years, the prevalence of diabetes is almost 15 to 25 times than that in the general population. So diabetics are very, prone for this cataracts. The preoperative precautions which we have to take in these cases are basically the endophthalmitis, because they are associated with the high risk of endophthalmitis. So we have to go for a good glycemic control before taking them for cataract surgery, and there should not be any evidence of ocular or periocular infection when we go for the surgery. And in intra-op considerations, the basic thing is like phacoemulsification is a better one. And because the anterior capsular phimosis is quite common in these cases, we'll have to go for a larger capsular rhexis. And pupils dilate very poorly, so you can go for the iris expanders or whatever it may be. And they are also prone for keratoepitheliopathy when they go for this cataract surgery. The IOL of the choice usually is a large diameter thing. The one which we want to avoid is a silicone lens, because subsequently if the patient requires a vitrectomy, if we are going to inject silicone oil, that's going to be a problem. So the cataract surgery and DME, the cataract surgery in diabetics is associated with increased risk of post-surgical edema, or there can be worsening of the pre-existing edema. So if you have a pre-existing edema, you can treat and you can go for. Almost 22% of these diabetic patients will develop some form of macular edema after cataract surgery. And this has to be explained to the patient, because they might be thinking that they lost the vision because of the cataract surgery. And Irving gas syndrome is almost 4 times very common in case of diabetics when they undergo cataract surgery. So this is one of the multi-centric study from DRCR net. Actually, in eyes with the DRCR, diabetic retinopathy with the non-CI central involving DME immediately prior to the cataract surgery. So they may have the treatment may increase the risk of developing CI DME 16 weeks after the cataract extraction. So timing of diabetic macular edema treatment, what we have to do is you can treat the macular edema adequately before the surgery. So there are 2 trends actually. Earlier, the trend was to extract the cataract till the BCVA was 20 by 100 or 20 by 200 due to DME development, and then they go for the cataract surgery. But now the trend is you go for the early cataract surgery so that you can identify and treat the DME quite early, because in the presence of your cataract, it's difficult to do a proper OCT also. Now OCT is being the guiding thing for treating all these macular lesions. I think clear media is better. So it's better to go for earlier cataract surgery and then to treat them. Again, in the post-DME, you have to differentiate that from Irving gas syndrome, because in case of a diabetic macular edema, you'll be having the background changes and exudations. And the OCT can also differentiate that whether it's a DME or just an Irving gas syndrome. And as far as management is concerned, now actually we have got an armamentarium right from the ranibizumab to Eylea to triamcinolone. So in case of bevacizumab, actually this is the result. So the short-term result says that IV bevacizumab prevents the diabetic macular edema and also reduces the CFT of eyes with the DME after cataract surgery. So in case if you inject this after the cataract surgery, so you can go for IVB if it is available. So this is about the CMT and the BCVA in these cases. Or we can go for ranibizumab or its biosimilars in these cases. So in patients undergoing ranibizumab treatment for DME and had a cataract surgery, they usually, gain 2 lines from the, pre-op surgery at the end of 1 month. So you can go for either bevacizumab, and there is a trial on subtenon versus intravitreal, but usually subtenons are not given much nowadays. We go for intravitreal. So if you take both the BCVA and the the central macular thickness, there's not much of difference between the two, but anyway, we usually prefer IVT in these cases, but there is always a chance of raised intraocular pressure in these cases. So the other one is you can have either one of these two, either bevacizumab or triamcinolone injected for this. But again, the problem
presentation is there's a lot of overlap in these presentations. So there's no pathognomic.
Yeah, you have to ignore that sound.
Okay. So there is a sustained reduction in the central macular thickness if you are using a triamcinolone acetate when you are injecting this in patients with the diabetic macular edema during the time of cataract surgery. The last choice which we usually prefer is the Ozurdex, which is a depot release. When you do that concurrently, the results are quite good. So in diabetic patients with macular edema and usually significant cataract, if you combine the phaco with the Ozurdex, it is better compared to phaco without Ozurdex with macular edema. So it's better, we can go for these things. But only thing is the cost of the phaco emulsification with the Ozurdex will be escalated and affordability will become poorer actually. So these are some of the cases where we have done a concurrent treatment of cataract with the macular edema. But most of these patients, even though we say HbA1c less than 10 is preferable, in many of these cases above 7 they don't do well actually following cataract surgery, and usually they'll be having dyslipidemia and the renal problem also. So this was the baseline vision when we started off. The patient was given a dexamethasone implant. So at the end of 1 month, this was the status of macula. Still, you can find a lot of hard exudates. The vision improved to 6.6, and the pre-op vision may be reduced because of the.
Sir, I request you to please conclude.
Yeah. So this is one of the problem. Like when we want to treat a patient prior to the cataract surgery with dexamethasone, this what has happened. The implant was directly injected into the lens, and this patient was taken for surgery next day free of cost. In fact, we released the dexamethasone implant and it was just pushed into the vitreous cavity. Pars plana lensectomy was done and IOL was implanted in these cases. So to conclude, actually, any of these agents can be used, but the dexamethasone implant is a choice, but care must be taken to avoid accidental injection into the lens if you are injecting pre-op. And of course, the chances of posterior capsular rent is very high, and during the cataract surgery because of, the migration of this dexamethasone. So in conclusion, actually, it's better to go for post-op treatment of diabetic macular edema, take the cataract early in these cases. Thank you.
Dr. Avinash, I have a very simple question to you after hearing all of what he said. What is the role of intravitreal steroids with a cataract surgery in a diabetic patient?
I can, it's a very good question, because we know that, as Naresh had spoken, if there is even non-center involving macular edema, the chances of macular edema happening after cataract surgery is very high. And because the chemokines do get liberated, the various types of chemokines do get liberated. Now, from that point of view, we have to take adequate precautions. And I do believe in my patients, I do advise concomitant intravitreal steroid injections, whether it's going to be triamcinolone or if it's going to be dexamethasone, irrespective of what the patient can afford. But if the patient has diabetic retinopathy with non-center involving, or center involving, I do advise concomitant intravitreal steroid. I don't prefer anti-VEGF as the first because it is very target specific. It just takes care of one chemokine, because there's a lot of other chemokines which get liberated. Steroid would be the drug of choice, and it takes care in the next 3 months.
Thank you. That